Thank you, sir. Good afternoon, everyone. I'll be talking about the clinical case. So we have Mrs. X, a 62-year-old lady, resident of Delhi, homemaker, never smoker, with no past history of TB or COVID-19. She has no significant exposure history. She presented to us with a history of hoarseness of voice for the last 2.5 years, a left-sided neck swelling for the last 1 year, and dyspnea for 5 months. Her history of presenting illness was again significant for the hoarseness of voice for the last 2.5 years. The left-sided neck swelling she noticed about 1 year ago, which was progressive, non-painful, with no history of redness. Dyspnea was also there for the last 5 months. It was now MMRC grade 2 and it has been progressive with an insidious onset. And in the background, she also gave a history of anorexia and weight loss for the past 2 years. History of the negative history was actually not very significant. There was no constitutional symptoms, no palpable swellings elsewhere, no other respiratory or cardiac symptoms, no other mediastinal symptoms, and review of other organ systems was unremarkable as well. She was a known diabetic and known hypothyroidism for the last 10 years, and both were well controlled. Her family history and personal history were not significant. And she had, for her symptoms, she had actually undergone a CT scan at an outside hospital and multiple needle samplings for the same, but no definitive diagnosis could be established, and she was not treated for the same outside either. So she initially presented to the IRCH wing of AIIMS, and initially a review of her outside slides were done. Following this, it was inconclusive, so ultrasound guided biopsy of the mass was done twice, and there was no conclusive diagnosis after multidisciplinary discussion with the pathologist. So she was referred to the Pulmonary Medicine services for further management. When she presented to us on examination, she was conscious, oriented to time, place, and person. General physical examination was normal. She was vitally stable with no respiratory distress. On examination, we can see that she had a left-sided mass, which was left-side fullness with some visible veins, and on palpation it was firm, located deep, and the inferior margin could not be delineated. Respiratory system examination was significant for a trachea shifted to the right and a sternal percussion that was dull, and the remainder of the systemic examination was normal. The hemogram and basic metabolic panel, apart from some mild anemia, was normal at 2 time points. And we had initially gotten an X-ray when we had admitted her for evaluation, and this showed that there was some mediastinal widening along with tracheal deviation to the right. And to discuss further radiology, I would like to call upon Dr. Damani, SR Radiology, for the same.
So coming to the radiology part of it, so the first ever scan, which was done on December 2020. So this scan is a CCT chest, which shows an heterogeneously enhancing, ill-defined, infiltrative left cervicothoracic mass that we can see, and the mass is So the mass is encasing arch of aorta as well and abutting its branches proximally without causing any luminal compromise. Based on just these images, we kept a differential of initially inflammatory or infective etiology, such as a conglomerated lymphadenopathy, IgG4 disease, as well as a neoplastic etiology, and however another possibility of thyroid mass extending retrosternally cannot be ruled out on this. So the next scan, which was done 2 years later, on March 16th, so we can see that the mass has increased in size. The mass is now encasing the branches of arch of aorta as well and causing mild luminal compromise of the same. The mass can be seen epicentered mainly in the mediastinum, and it is uplifting and contralaterally shifting the left lobe of thyroid with ill-defined fat planes. So it looks more like a mediastinal mass, which is causing mass effect on the thyroid gland. And FDG PET was done in the same year, in the month of December. The mass is still encasing the vessels, and it is heterogeneous and lobulated and infiltrating the left lobe of thyroid, and shows extensive FDG avidity as well. And follow-up X-rays shows the increase in size from April to December 2022 with tracheomediastinal shift. So basically, it was an infiltrated progressive soft tissue mediastinal mass. It had no calcifications or fat density, and it had few heterogeneous necrotic areas. So we kept a possibility of inflammatory IgG4 related disease, ruling out the infective etiology. The lung fields were normal. as we can see. And second DD of slowly progressive lymphoproliferative disorder, and third a rare possibility of mediastinal aspergillosis in an immunocompetent patient. Okay.
Thank you, Damini. So we have now a 62-year-old lady who is a known diabetic with hypothyroidism, symptomatic for the last 2.5 years. She has a contiguous anterior mediastinal mass and a neck mass with progressive increase in the size, which is now encasing the vessels, and it was also compressing on the airways with some tracheal compression and shift. So looking at the mass is the differential diagnosis for the mediastinal mass. Because we had a superior and an anterior mediastinal mass, we were mainly looking at lymphomas or masses of the thyroid process, or masses of the thymic process, or germ cell tumors. So we worked her up along these lines initially. She is a known case of hypothyroidism, and we just repeated a thyroid profile that was normal. For lymphomas, we did a blood marker of LDH, which was again normal. And for germ cell tumors, we had an AFP and a beta HCG, which was normal. So following this, she had actually undergone multiple biopsies previously, an outside CT guided biopsy of the mass, 2 ultrasound guided biopsies at AIIMS. And when she initially presented to us, we had also done a cervical mass or lymph node FNAC. And all of these so far had turned out to be inconclusive. So following this, based on our radiological discussion, we had gone ahead with further investigations, at least blood investigations that could help us. So for IgG4 related disease, we had looked at serum IgG4 levels and total IgG also, but these were normal, and the ratio to the total IgG was normal as well. For a very low down parathyroid mass, the calcium and phosphate and the IPTH were all normal. And for infective pathologies, like they suggested, the serum galactomannan for aspergillus was negative, and urine histoplasma antigen at this time was negative as well. So this was actually published in the NEJM in 1964. So in the discussion of mediastinal tumors, Dr. Edward D. Churchill had suggested that any diagnosis short of a histological one is at best an educated guess. So despite multiple diagnoses and despite multiple blood investigations, at best we could just make a differential for this mass, and we did not have a conclusive diagnosis as of yet. And we knew that the final diagnosis would be made on histopathology itself. So we had 2 ways of sampling the mass. We could either go for a surgical biopsy or a surgical excision, or we could sample the mass with slightly minimally invasively by an EBUS guided FNAC. The surgical biopsy would be having more morbidity actually. So we went ahead with an EBUS guided FNAC, which was done. We can see the mass that is showing up here on the ultrasound along with the needle that is sampling the mass. The bronchoscopy at this time revealed a left vocal cord palsy, which might have been explaining the hoarseness of voice. So following the EBUS FNAC, I would like to call upon Dr. Priyanka for the pathology review of the biopsy so far.
Thank you, Dr. Sujay. I am Dr. Priyanka, a pathology senior resident. So we received the pathology samples of this patient, and there are multiple samples: FNA biopsy and from neck mass, EBUS TBNA and biopsy for mediastinal mass, and all showed similar pathology. This is the scanner view of the ultrasound guided biopsy for mediastinal mass. We see a fibroglanginous tissue core with polymorphous population of mixed inflammatory cell infiltrate. This is the high power view in which we see the lymphocytes and histiocytes. These are the histiocytes and these are the lymphocytes. Yeah, so we first of all gave the thought of sclerosing mediastinitis based on the thick collagenous bundles which looks like dense keloid like collagen, and we did the fungal stain and ZN stain on this sample, which was negative. We did the IgG4 staining, which was also negative. Lymphoma IHC panel was done, which was also not suggestive of any lymphoproliferative disorder. This is the EBUS mediastinal mass, and we see they are singly lying in some few clustered histiocytic population. This is the EBUS clot core biopsy, which is more cellular than fibrotic. This is the lymphohistiocytic processes of the same biopsy. We did special stains for fungus and AFB, and they were all negative. Then we run the panel for the lymphocytes. We see that there were more number of CD3 positive T cells than the CD20 positive B cells. There were few plasma cells also highlighted by CD138. So, and we did the other panel of IHC to rule out our differentials. So by CK and TDT being negative, we ruled out thymoma. CD30 and CD15 was negative, so we ruled out Hodgkin lymphoma. Along with EBV also we ruled out Hodgkin lymphoma. IgG4 was negative, so we ruled out IgG4 disease. CD1A and Langerhans was negative, so we ruled out Langerhans histiocytosis. S100 negativity ruled out Rosa-Hoffman disease and interdigitating dendritic cell sarcoma. While CD21, CD35 and clustering, they ruled out follicular dendritic cell sarcoma. The ALK negativity ruled out the ALK positive histiocytosis. So, and we did the marker for our for macrophages. They were diffusely immunopositive for CD163 and CD68. So, based on our histomorphological and immunohistochemical parameters, we thought of suggesting a diagnosis of non-Langerhans cell histiocytosis, which is histiocytosis NOS. Thank you.
We're coming to the further course. So because we had a diagnosis of histiocytosis and we initially wanted to look at systemic manifestations also. So we initially did a pituitary function in the blood which was normal. We wanted to look at the fundus, we wanted to look at the heart as well. So we got a fundus evaluation, we got an ECG and a 2D echo, and these were normal at this time as well. We had gotten a PET scan to look at bone lesions and to look at any FDG avidity anywhere else. However, only the mass was showing up on the FDG PET CT and there were no bony lesions or any lesions anywhere else in the body. Because the brain could not be seen, we had gotten an MRI brain with a contrast enhancement done. We can see that MRI brain showed this ring enhancing conglomerated lesion in the right temporal lobe. So finally, we had actually a diagnosis of non-Langerhans cell histiocytosis or histiocytosis NOS after nearly 6 or 7 biopsies and multiple discussions with the pathologist. And this had presented only as a mediastinal mass and as a brain lesion. So we had included the medical oncology team, we had consulted them, and we had gone ahead with the further management of the patient. So the patient initially was treated with vinblastine and prednisolone. She received both of them for about 6 weeks. And we can see that the prominent veins that were there have disappeared, and this fullness that is visible, this has also come down. And the patient herself had said that her hoarseness of voice and also the neck swelling that she used to perceive has come down. So to discuss the follow-up radiology, I would again like to call upon Dr. Damani.
So continuing with the follow-up using radiological investigations, so we can see in a span of 3 months from November 2022 to January 2023, there is reduction in the mediastinal widening as well as the trachea, which was earlier shifted and also shows mind-luminal compromise, is now moving back to the center, and lumen is also, the caliber is also improving. And comparing the FDG PET scan done in December 2022 to January 2023, there is reduction in the size of the cervicothoracic, left cervicothoracic mass, also as well as reduction in the avidity of the mass. And the follow-up MRI scan again done in January compared to the November 2022, we can see that the conglomerated irregular ring enhancing lesion in the right medial temporal lobe shows reduction in size as well as reduction in the enhancement. So after treatment, the follow-up PET scan as well as the follow-up MRI shows reduction in the size and avidity of the cervicothoracic mass as well as the brain lesion. So this is partial response to treatment. Thank you.
Thank you, Damini. So I would now like to call upon Dr. Benin to discuss the review of literature.
Coming to the discussion of histiocytosis. So histiocytosis can be called as a group of diseases characterized by the accumulation of specific cells thought to be derived from the dendritic cells of macrophages. Long ago, over 100 diseases described by various pathologists were grouped by the working group of histiocytosis in 1987. So initially they were classified as Langerhans cell histiocytosis, non-Langerhans cell histiocytosis and malignant histiocytosis. Recently in 2016 there was a revised classification which was proposed. This grouped the histiocytic disorders into 5 groups, which are the L group, which includes the Langerhans group. Here we can see the LCH and the previous non-Langerhans diseases like Irvine Chester were also included in the L group. Next comes the C group, which has diseases with predominant cutaneous and mucocutaneous manifestations. The malignant M group consisted of the malignant histiocytosis, and the R group consisted of Rosai-Dorfman disease and associated disorders, which mainly presented with large masses, especially as a painless bilateral massive cervical lymphadenopathy. The H group consisted of hemophagocytic lymphohistiocytosis and the macrophage activating syndrome. However, in some cases, even after this classification, a definite diagnosis in one of these labels cannot be made. In these cases, sometimes they are labeled as histiocytosis, not otherwise specified as seen in our case. So what about the mediastinal involvement in histiocytosis? The mediastinal involvement in histiocytosis is very rare. After literature review, we were only able to find 2 case reports showing predominant mediastinal involvement from histiocytosis. The first case was from 2008. This was a report of LCH, which was originating the mediastinum in a 55-year-old male, and he was treated with cladribine. The next case was a 60-year-old male, another patient. He also presented with an anterior mediastinal mass, which after surgical excision using VATS was diagnosed as a case of Erdheim-Chester disease. Now, what are the treatment options we have? The following are the treatment options, but due to the paucity of the number of cases, we do not have a very definite guideline regarding the treatment. The chemotherapeutic drugs are cladribine, vinblastine and methotrexate. The immunosuppressive drugs used in the treatment of histiocytosis include corticosteroids, pegylated interferon alpha and anakinra. Recently, targeted therapy has also evolved. Due to the involvement of the MAP kinase pathway, identification of the BRAF V600E mutation can be targeted using the BRAF inhibitor vemurafenib. Also, case reports of using MEK inhibitors like trametinib are here. So, what is the prognosis? It varies based on the site of the disease and the response to therapy. In a large French cohort of 165 patients, we found that there was the overall survival was associated with advanced stage, that is the worst overall survival was associated with advanced stage and diseases involving the CNS, lungs and retroperitoneum. The survival data has also largely varied in the literature published in the last 20 years. In the earliest study, which was published in 1996, there was only overall survival of 5 years, only 43%. However, in the recent study published in 2018, the survival has gone up to 83%. So, in conclusion, histiocytic disorders are rare and they are challenging to diagnose, and predominant mediastinal involvement is even more rare. And the treatment involves immunosuppressive therapy along with chemotherapeutic drugs. And however, it is not yet well defined due to the lack of clinical randomized trials. Thank you. I would now like to invite Deepam Pushpam sir to provide his expert comments on the case.
Coming to the treatment approach in brief, so if we go by the literature, so all these groups are clubbed into non-Langerhans cell histiocytosis. So we should ideally do the mutation first. If BRAF mutation is positive, we should go for vemurafenib, and if MAP PRK mutations are there, then we should go with cobimetinib. The issue is that these mutation testing is not routinely available at our institute. Second thing, these drugs are not available at present in India outside clinical trials. So availability of the drug is an issue. Third point is that these drugs are poorly tolerated, with approximately 30 to 40% of patients having grade 3 and grade 4 side effect, adverse effect. Then in the group which mutations are negative in Western country, cladribine is used as the preferred drug. The issues with cladribine is cost. It costs around 3 to 5 lakhs in Indian setting for a course of cladribine, and infection and myelosuppression are the key toxicity concerns, whereas the other drugs are vinblastine, steroids and methotrexate. So at IRCH, our approach is that we use LCH3 protocol, which is the same protocol which is used to treat Langer cell histiocytosis, and we give vinblastine plus prednisolone induction for 6 weeks. After 6 weeks, we assess the response. If it is a complete response or a partial response, we continue vinblastine prednisolone for 6 months. If the patient does not respond to vinblastine or prednisolone, or it's a progressive disease, then we give cladribine. And most of the patients respond to vinblastine and prednisolone. In few patients, we need to give cladribine. Dr.
Thank you, Dr. Deepan. So as we saw that this was a diagnostic dilemma which has been there for last 2 years, and eventually with the help of our radiologists and pathologists, we were able to reach a conclusive diagnosis and help the patient with the treatment plan. So I would request Dr. Anand Mohan sir or other faculty members from the department, or the case is now open for discussion and comments. Yes. But BRAF based therapies are kind of not available anyways. So. Yes. No, sir, they are available, but we are. Yes, but we are not using it here. So it is done. It was done in this also. So histiocytosis is not very uncommon, but presenting as isolated mediastinal masses.
So what happens is that if you see the picture, it's like initially for a garden variety of mediastinal mass, just like we investigated lymphoma, sarcoma, all those things are in the but after 5 biopsies we did not get anything. So basically it was the localized environment, the area of environment probably made it difficult to think like that. Otherwise, if we start looking all over specifically, then it will not be so rare. But with this presentation,
for mediastinum, it's rare. Because microthoracic mass which is infiltrating like this, moving the great vessels turning out in this age group to be histiocyte is rare. I can't recall about this in that picture.
So just a comment on the question, I think so it looks like fibrosis biopsies to reach a diagnosis. So I think is it so how to suspect this condition and what causes it to be missed? I mean, so maybe I have also input on that. How can a reporting pathologist at periphery suspect this at the first?
So this is very difficult to know. It is a pathologic diagnosis. So for example, the first biopsy we saw only fibroinflammatory kind of process. We say this is a sclerosing mediastinitis, it was a mediastinal biopsy, and then since the sclerosing mediastinitis is the diagnosis of exclusion, other things should be worked up and investigated. For example, we can do only bark stains like fungus and AFP, but then it has to be proven by other methods. For example, in this case, we will use to So everything has to be investigated on clinical front as well. We have just a small biopsy, we can do that only. And apart from that, we reached the diagnosis of histiocytosis when we have done everything and clinically there was no clue of any other diagnosis. And then we stained it, we found out, okay, this is predominantly histiocytic process and we are not finding clinically anything. Special stains for Wagner negative all the time, lymphoma was negative, lymphoma panel was negative, IgG4 was excluded, and then it went. So it is always a clinical pathologic diagnosis. We have to exclude other things before labeling a particular case as histiocytosis. So that has been done in this case. In fact, the first FNA was done from the neck mass, and it was showing dual population of cells. It was outside FNA, one slide we received, and it was diagnosed as thymoma. Because in thymoma also there are two types of cells, thymocytes and the epithelial cells. So on cytology they look like histiocytes can look like epithelial cells. So once diagnosis of thymoma was also rendered in this case. So that is why it takes time to establish a diagnosis until we get a MDE on this case. After that the diagnosis is established.
Was it that the last slide which is focused the macrophage markers were they the one that changed?
So macrophages were always there in any fibroinflammatory process. If it was because of histoplasma, for example, you will see so many histiocytes. So that's not specific for histiocytosis.
What the median spermoscopy would have been better than EPAS. That's just would have got a better sample doing a median spermoscopy and biopsy than doing EPAS.
I would say that sampling was never an issue on this case. He was quite self-evident. He always had that was not the case. But the only thing was exclusion of this.
Take the overall.
So I think the era of minimal interventional procedure for the biggest panel which is close to the neck. I think EBUS is a very it's the first go procedure for a median or paratracheal or paramontial in today's. I think the median scope with reach is limited because it's anterior paratracheal penetration and a lot of stations are not approachable. But I think that is in experience and also with a negative EBUS or negative biopsy, that is something should be done.
It's here. If you go by this.
I think maybe if that issue was not available by the other means, then one would have gone for medicinal therapy. But I think the issue cellularity was always there.
Yes.
The thing is that let's go. And we have all this that is.
One comment regarding the gravity of the disease. We have at present at our we have a database of 15,000 patients. Out of 15,000 patients of all malignancy, we have only 110 patients of LCA and round about I think 45 patients of non-LCA. So one can calculate the numbers. Second thing that approximately in 3-4 patients we receive presentations from the derma where we ask them to treat, and if there is a chemotoxicity we just give them the supportive care. And 3 to 4 patients may be registered. But it's a rare disease. Since AIIMS is a tertiary care center, we do lot of it. We do get, but outside AIIMS it's a rare disease. Second thing regarding the drug, all drugs are available, it's not an issue, but most of the patients in ICL somehow they can't afford it.
Yeah.
One is profile having a different institute.
Yes. Yes. So I think that was a very fruitful discussion. So now we close this case and yes, sir.
Question is that if perhaps it needs vaccination plan or vaccination for psychiatric disorders. And the comment is, it's a very common Indian method of saying hoarseness of voice. There's nothing else in the body that can become hoarse, so this hoarseness would be added.
So that the second comment is good, which we discuss in our case discussions routinely when a resident presents hoarseness of voice. So we ask can anything else be worse? That it's not possible. So obviously, so that I agree. We did not evaluate formally for an olfactory issue. We did this MRI after we got the biopsy discussion. So at that point of time, we had thought that it is the same process. So we had initially discussed with neurosurgery, also neuroradiology, also whether we should biopsy this very lesion to look for an alternate etiology. But however, we did not do a formal olfactory evaluation and not biopsy, and that has also responded to the treatment. So I think now we request the plastic surgery department to go ahead with the assessment.
Thank you, sir. Respected faculties, seniors, residents, ladies and gentlemen, I welcome you to today's CCR. It is this one. I welcome all of you to today's CCR being presented by Department of Plastic Surgery. The title is Bone is More Than Skin Deep. So I am going to tell you about a 22-year-old female. She was a college student. On 24th October 2022, on the day of Diwali, while lighting a diya, she got burned and she was taken to a local hospital. In the local hospital, fluid resuscitation was started, dressing was done, and around 1 a.m. in night, she presented to us to the burns casualty. So as per the advanced burn life support guidelines, we did a primary survey. The airway, breathing, circulation, all found to be normal. There is no disability. And so this is our casualty, burns casualty. So we do a primary survey, we do weight assessment, and in wound wash, we do all saline wound wash so that all necrotic or debris is all removed. And her weight was 46 kg. Now coming to the secondary survey, in secondary survey there was no allergies, and she is a patient of systemic lupus erythematosus. She was diagnosed in 2014. She was on 4 drugs: prednisolone, mycophenolate mofetil, tacrolimus, and hydroxychloroquine. Now, while lighting a diya at her residence, she got burned. Her father doused the fire. You can imagine a 22-year-old female lady, a college student, with such a major burn and with comorbidity. This was the burn wound assessment. As per the Lund and Browder chart, she was about 40% second degree and third degree, involving back, bilateral buttocks, bilateral lower limbs, and right upper limb. Now this is the wounds she presented at our emergency. We did a thorough bath with saline, soap and saline. Contaminant debris are removed, and we applied nanocrystalline silver dressing at that time. Now you can imagine, with all those injuries and SLE, the prognostication. So we do a prognostication based on modified box score. What that calculate? That is age, total body surface area burn, and with inhalational injury factor. And it comes to around 62%, which is quite high. So we prognosticated, we told the parents that this is the scenario. Along with that, fluid resuscitation continued, analgesia was given, and since she was being treated for SLE, a rheumatology consultation was given. Now, these are the anticipated problems. I now request Dr. Komal to continue the further discussion.
As our patient had 40% TBSA burn, along with the background of SLE, there were few problems that we anticipated. Our patient had lupus nephritis, so we did a closed tightening of the fluid resuscitation. We wanted to avoid over and under resuscitation for the patient. She had cytopenia, lowered immunity, and she was on high dose of ongoing immunosuppressants. She had delayed wound healing due to SLE and the immunosuppressants. These are the factors which could lead in the worsening of the burn wound sepsis. and we also were suspicious of stress-induced worsening of the SLE. So we made a multifaceted plan for the patient. We wanted to do wound cover for the patient, and antibiotics were given based on the culture sensitivity. Thromboprophylaxis was performed. After discussion with the rheumatologist, we started tapering the immunosuppressants of the patient. But we faced many issues during the management of this patient. She had multiple low-grade fever spikes, her cytopenia worsened, her C3 and C4 decreased, her hypoalbuminemia worsened, and she had psychiatric symptoms. So we were faced with the dilemma whether the patient had an SLE flare-up or she had burn wound sepsis. SLE flare-up would require increasing the dose of immunosuppression, but treating the burn wound sepsis would require immunomodulation and decreasing the dose of immunosuppressants further. Along with these, this patient had a past history of chickenpox, and during the hospital stay, she had reactivation of the herpes zoster in the left mandibular C3 and C4 dermatome. So for the burn wound management, we performed routine bedside wound washes every alternate day. As there was extensive involvement of the body, 40% TBSA was involved. So she also underwent multiple settings of wound scrub and debridement under general anesthesia. And we performed skin grafting on post-burn day 71. So as we can see, these are the images on arrival. There were mix of second degree and third degree burns. With time, there was heavy colonization of the burn wound with the bacteria. So we performed regular wound washing and debridement of the wounds. We were able to decrease the bacterial load, and the wound healing started on the edges, as we can see in the last images. But in most of the patient, by the end of second and third week, most of the second degree burn areas start healing, and we are left with only third degree areas. In this patient, due to the SLE and the high dose of immunosuppressants that the patient was on, there was delayed healing. So we had to wait for the grafting. But after this long and tedious journey, we were able to take the patient from 40% TBSA burn to less than 4% TBSA burn. I would like to invite Dr. Ranjan Gupta sir to discuss regarding the SLE of the patient.
Thank you. So this patient was diagnosed with lupus in 2014, and over time she has had undulating course of her illness, which included episodes of cytopenia as well as episodes of renal nephritis. When she sustained burn, just before that, 2 months back, she had had a relapse of lupus nephritis, and she was started on mycophenolate, tacrolimus and high dose steroids before coming to the casualty. Now, in this patient, the contest of this fire versus flare posed unique challenges in managing the patient. As has been explained by Dr. Komal, patient had leukopenia and a worsening renal involvement, which would have further worsened had she not been given steroids and immunosuppressant and warranted treatment with these drugs. Whereas if we continue giving these drugs, we were anticipating problems of delayed wound healing and thereby increased chances of wound infection. But in such a case, when the emergent problem was of burns, which could have been life-threatening in her case, the later two reasons take weightage, and we decided to stop her immunosuppressants and continue only on low-dose steroids. Now, in such a situation, there are no established guidelines, but then taking cues from what we do in patients who have infection with lupus flare, we taper down the steroids in first day itself on 20 milligram, and then we decided to taper it to further as low as possible based on her response to treatment. Her immunosuppressants, that is tacrolimus and mycophenolate, were stopped. Hydroxychloroquine was continued because it doesn't cause any further immunosuppression that could give rise to more infection. Initial course of steroids was given under the cover of antibiotics. In such a situation, we had to monitor not just her burns, the progress of her wounds, but also the progress of her disease. So we had only two guiding principles. Clinically, we could assess the progress of her burns, as has been shown by Dr. Komal. And for lupus disease activity, we basically took the parameters of total leukocyte count, complement levels, and proteinuria, and we serially monitored. We ensured that we use the lowest possible dose of steroids just to maintain TLC above 4,000 total count, and continue that. Now, over time, once she had shown initial improvement in first 1 week, we decided to give her immunoglobulin, IV immunoglobulin. Now, this wonderful drug by its various mechanisms of action, can act not just against the disease activity but also against the infections, as has been shown in the picture. So if you see the upper half, these mechanisms are mainly there to prevent the infection related complications, whereas the lower half is usually, it is postulated that they act against the disease. And as we see that on day 1, when she had high TLC, low complements, low albumin, after giving IVIG, after first 10 days, all had started improving. They had taken off with the steroids itself, but IVIG maintained that. And as we can see that post-op, you can see the post-burns day 1 and pre-burn values, complements had normalized, albumin had picked up, total count and platelet counts had also improved. Thank you.
May I request Dr. Amit from anesthesia to present?
Good afternoon, everyone. I'll be discussing about critical care management of this patient. So, as we all know from the timeline, the patient was received in ED at 1 a.m. The patient was shifted to the critical care unit at 2:30 a.m. The indications for ICU admissions were 40% TBSA burn, fluid and electrolyte resuscitation, hemodynamic monitoring, anxiety, analgesia management, that is background and procedural. So also with the discussion, we know that patient's airway was patent, she was spontaneously breathing and hemodynamically stable. Coming to the fluid resuscitation volume for first 24 hours was calculated with the help of modified Brooks formula, that is 2 ml per kg per percentage TBSA, and that came out to be around 3.2 liters. And total fluid the patient received was around 4.8 liters. The additional boluses was based on POCUS, IVC collapsibility and goal directed fluid therapy with a target urine output of around 25 to 50 ml per hour. These are the serial ABGs. We can clearly see that by around 21 hours post admission, the patient's lactates and base excess were settled. Coming to the pain management, we follow the concept of total pain, that is with the management of physical pain, we also manage psychological, social and spiritual aspects of pain. Coming to the physical pain, we background anxiety and analgesia is managed with the help of paracetamol, tapentadol, pregabalin, dexmedetomidine, etc. Procedural sedation and analgesia was managed with the help of fentanyl, ketamine, dexmedetomidine, propofol in alone or in combination, and breakthrough analgesia was with fentanyl and NSAIDs. Coming to the sepsis management, so the patient was started on injection augmentin 1.2 grams IV TDS on admission because the patient was immunocompromised and having more than 40% TBSA burns. By day around 7-8, she started having fever spikes of around 1 or 2 and was started on meropenem and teicoplanin, because along with this she was having a TLC count of around 2900, high procalcitonin, and wound cultures and other cultures like blood and urine were also sent. So by day around 6 of cultures, so we received the blood culture that we received wound culture that was that showed Pseudomonas aeruginosa, and so teicoplanin was stopped and meropenem continued for another 4-5 days. So it was stopped by day 10 based on clinical improvement, TLCs and procalcitonin trends. Coming to the nutritional support, we gave high calorie and high protein diet. Early enteral nutrition was started within 24 hours. Calorie calculation was done. Usually we need around 25 to 30 kilocalories per kg per day for the ICU patients. Additional 1.5 stress factor was multiplied for burns, that is for 40% TBSA, and calorie targets were achieved around 3 to 4 days after ICU admission with high protein diet, and vitamins, micronutrients were added. Coming to the supportive care, head end elevation and frequent repositioning was done to avoid bed sores. Thromboprophylaxis was done with injection Clexane. Glucose control was achieved. Serum electrolytes were monitored daily and replenished, and delirium prevention with adequate analgesia, hydration, ambulation and family support was done. In spite of these, we needed psychiatric help. So I'll call upon.
May I request Dr. Rahul to come and present
Thank
the psychiatric aspects. Thank you.
Thank you, sir. So coming to the psychosocial aspects of burn, so the reason for psychiatric referral was significant distress and associated crying spells, which were seen during the ward course. On the initial examination, it was seen that there was sudden onset of crying and agitation. Her speech was goal directed, and her speech flow was decreased during the initial mental status examination. In her thought content, she reported of apprehensions about future and reported ideas of helplessness. But the important thing to note is that she denied any ideas of self-harm. So the challenges in front of us were first the acute crisis management. Secondly, as we know, the patient had history of SLE. So there can be SLE-induced worsening of SLE. And that patient, she was already on multiple immunosuppressants and immunomodulators, which are known to cause or precipitate depression and psychosis. Therefore, it was important to rule out any possibility of suicidality in this patient. Furthermore, long-term consequences which are associated with burns, like functional limitations, visible scarring or deformity, chronic pain, and traumatic stress related to the initial injury. And taking all these factors together, they can be detrimental to the mental status of the patient as well as to her physical recovery from the burns injury. So after the initial evaluation, first of all, we ruled out any pre-morbid psychopathology, and none could be elicited in this patient. There was no prior history of any major depressive disorder, any psychotic illness, or any anxiety disorder prior to this event. So subsequently, supportive psychological interventions were started, which focused on immediate concerns like sleep, pain control, and protecting patients' coping strategies. So while evaluating these patients, one thing is important for us, that not only to take care of mental status of the patient, but also of the family members and the staff which is involved in the treatment of these kinds of patients. So after the initial evaluation, the diagnosis of acute stress reaction was made. There was no symptom suggestive of major depressive disorder at this point of time, and she was managed with the SOS doses of benzodiazepines and adequate pain control, and we decided to wait and watch for any emergence of any depressive symptoms or any post-traumatic stress disorder symptoms, and she didn't require any antidepressants. So the common questions which we encounter is, can these burn injuries be suicidal? And surprisingly, the answer is yes. Suicide by self-immolation is one of the most dramatic forms of all suicide forms. According to the national data, about 3% of the patients who died by suicide in 2020 and 21, they were due to self-immolation. And about 60% of these deaths due to self-immolations are female victims. And comparing the self-immolation group with the rest burn cohort, it is seen that the suicidal group, that is the patients who had these burn injuries due to suicidality, they had larger extent of burns, they have higher incidence of inhalation injury, and they required more surgical procedures. And here why I am mentioning about or emphasizing about suicide is that there are longitudinal studies available which states that those patients who were initially evaluated for accidental burn related injuries, in later subsequent follow-ups it was seen that they mentioned that injury was not accidental but rather a self-harm attempt. So it is always important in these kinds of patients to monitor for depressive symptoms in the follow-ups. So the long-term issues in this patient were to monitor her for PTSD symptoms, for depression, for sleep problems, and for nightmares. And secondly, though this patient denied any ideas of self-harm and she didn't had any previous history of self-harm, but one should always monitor, because the literature suggests that there is increased risk of self-harm or suicide attempts in future among these burn survivors. And lastly, a worsening of SLEs and increased complexities in management of SLE along with psychiatric illness. As I've mentioned earlier, the various medications which are being used for SLE, they are known to precipitate the psychiatric illnesses. Thank you.
Now may I request Dr. Nandini to present the review of literature, please?
Thank you, sir. So, with the thorough clinical case discussion background that we had, we now know what SLE is. So, it's a prototypic multisystem autoimmune disorder where interplay of environment and genetic risk factors leads to progressive loss of tolerance to nuclear antigens over time and finally culminating into a clinical disease. So, there was a thorough literature search that was done, and we found that there is paucity of literature on autoimmune diseases with burns. And among the wide spectrum of autoimmune diseases,
rheumatoid arthritis and SLE were the two most common presenting autoimmune related disorders that required admission with burn centers in the burn center. And apart from the burn injuries, there were two different spectrum again in this. One is the autoimmune related disorder which presented with burns, and the other, because of the reaction to the sulfur drugs or the immunosuppression, they presented with toxic epidermic necrolysis and Steven-Johnson syndrome. So that has a very similar presentation to burns. So these two spectrums are almost treated alike, and you can see the data over here that even though the survivors among the rheumatoid arthritis were 8 and in the SLE group was 7, the morbidity is always high. Because it needs a lot of modification in the immunosuppressants and also needs monitoring with the complement levels or the double-stranded DNA levels and requires a multidisciplinary approach. In our case, coming on to the treatment aspect, with the specific problems or the issues that were faced in our patient, in the different timelines, different dressings were used. So the nanocrystalline silver dressing, that is the ActiCoat, it was used because it has a wide and a broad spectrum of coverage against bacteria, virus, and even fungus also, even to the extent of MRSA organisms too. So they mainly act by inhibiting the respiratory chain in the cytochrome level, which inhibits the DNA binding and replication and causes free oxygen radical release that causes the cell lysis. Then we also faced delayed wound healing problems and also less fibroblastic activity, and the collagen strength was also less in wound healings. So we used recombinant human epidermal growth factor that binds to the EGF receptor present on the keratinocytes and fibroblast, and they stimulate the keratinocyte proliferation and alters the fibroblastic activity. One more dressing that was used in our case was, since she also had almost 25 to 30% areas of second degree burns, collagen dressings were used. They mainly are very helpful in second degree superficial burns and to some extent deep, which they act as a physiological interface between the wound surface and the environment, and they help in keeping the wound environment moist, which is very helpful for wound healing. Also helps in gaseous exchange also. They are non-immunogenic, non-pyrogenic, hypoallergic, and pain-free. And coming on to the fibrin glue, which was used in this case when we did the grafting, hypoalbuminemia was the main concern in our patient. So we didn't wanted to have a graft loss because of hematoma or the seroma collection, which usually is a most common cause. So we used fibrin glue that is composed of thrombin, factor 13, calcium, and fibrinogen, and that acts as a hemostatic agent. And we almost had 95% uptake of graft in our patient. So coming on to one aspect, the patient of ours had a dia burn. We always think that firecracker burns are more notorious and they are more harmful. But in the Indian Express, the Times of India headlines, you must have seen that even after banning crackers in multiple states, there were incidents of firecracker injuries also. But in our case, as we have seen, that dia burns are more fatal and they are more mortal, which is usually neglected. So that needs to be taken care of. And I now ask Professor Mani Singhal sir to.
Thank you very much. And the smile on patient is a military smile. I think the patient had a lot of grit and I think a lot of willpower that actually helped her to survive through. I think she had a very excellent family support. And I must congratulate my entire nursing team is behind the ICU team, the physiotherapy, the dietitian, all worked very hard they worked for all the patients, but this was very, very critical for us because any patient on steroid with such high dose steroid, having burns, even to take a small segment of graft from a patient having steroids is extremely difficult for us and we have a nightmare. So the patient came through all the journey of 60-70 days and she survived the entire journey. Was very, very pleasing for us, and I must congratulate my entire team before Dr. Subhashish takes on the discussion. Comments of Senior Professor Sir. Sir. any comment from rheumatology, Dr. Kaushik, you want to say something? So basically, if there is no question, I think we can utilize 4-5 minutes just to tell that how do we manage, how differently we manage burns and how better we can become. So basically, we have now, we have started the service around 11 months back, and we have admitted around 700 patients till now, and I think 700 is the number, and I think the initial, the number has doubled in last 6 months, and even the last month has almost 5 times numbered the entire winters, the bonfire, Diwali, and I don't know the exact stats of the neighboring burn center, but I think we are almost equivalent to them in terms of numbers right now. And our nursing team is extremely dedicated. The infrastructure is good for burns treatment, and that is making a lot of wonders for these patients. We are now having a couple of pregnant burns, pediatric burns. A lot of departments are supporting us. I think the front runner is the critical care, the entire support of anesthesia team. The entire fluid management has changed. Now we don't use much of the common parameters which is used for fluid management. They use direct ultrasound guided fluid management, and I'm sure that with coming times we can definitely, this part of globe has maximum burns, and I'm sure that we can have what works in our weather, what works in our country, and our setup is more important for us because we are following most of the Western literature right now, and I'm sure that our team can do wonders on that. And with this I will close now. Yes, please. Yes. Mike.
Just a question, and HKH should not have any features of infective sepsis. So in that case, do we consider a possibility of a stress-induced Edisonian crisis in reducing steroids? That is one. And the second question is to the treating team. We are in respiratory medicine. We have a lot of patients who have hypoallergenia, critically patients who have dead sores. So, what do you think would be a possible kind of dressing that we could kind of routinely implement in our patients when we happen? Thank you.
Then you can answer first.
So the first part is that it's true that we should consider a possibility of stabilizing. That is why initially she was given early hydrocortisone. But again, giving hydrocortisone for longer duration is not possible. So initially after 48 hours, we should to overnight. She was able to maintain, and then it was titrated based on a single app.
So I'll just use this opportunity for pressure sore. Pressure sore is mainly a nursing problem which has to be handled through good nursing care. Dressing is very secondary. A nice, neat bed sheet, frequent change of posture is the most important thing. I think dressings are not that important, but dressings again depend upon the depth of the lesion. They may just a normal saline dressing or a normal mupirocin dressing is sometimes enough for a very superficial pressure sore. To the very deep pressure sore, those are the ones in which we use negative pressure wound dressing after thorough debridement. Quite often the department gets a call for a surgical management of a pressure sore. I think the surgical management or a surgical cover has one basic principle. Any patient who can turn on his own is a candidate for any reconstructive procedure. If the patient cannot turn on his own, means not on his own, means with some support, with some railing or some support, then only any surgical option will work on that patient. Otherwise, there is a 60 to 65% failure rate within 1 year of reconstruction or 1 year of any flap cover. So we are very reluctant on doing any flap cover for those patients whose neurological conditions don't improve with time. Any patient who will improve neurologically with time, we can definitely offer some surgical cover to them. Otherwise, it is hardly any reconstructive procedure which will benefit the patient. So, you want to add something? Yes.
We might just again Dr. Ranjan. People are extremely heavy immunosuppression. Both steroid, microphenolate, CQS, acrolemus. I was wondering why acrolemus is acrolemus. If you are in this situation, you are very extremely necrotic.
So this patient had a long history of lupus, and in the first episode of nephritis, she was treated with microphenolate alone. This time she had a relapse, and she was already on treatment for almost 2 months before she came to us. And again, with that treatment, she had response in her major organ and other symptoms, But proteinuria was terminated. So tacrolimus is not a drug that is daily used. But when the patient's problem is only ongoing proteinuria, with presence of other symptoms and signs, then we do add tacrolimus. This patient was already taking it from elsewhere. She came to me for 2 months just taking it from elsewhere. That's how it happened.
From us?
Just a small comment. You commented go to antibiotic as the first visit. Just asking whether we have a, for us, people, if there's an immunocompromised setting, with infection, we give pseudomonas cover or something as an upfront agent. So just asking, do we have some kind of protocol or there's a standard go to antibiotic in burn setting?
So, sir, actually, we don't use any antibiotic regularly for acute burns. On around third day, there is wound colonization, and based on that bacterial culture, we use antibiotics. But if the wound is very contaminated, if the patient is dirty or some contamination there, then we first start augmentin as a first line of drug. Second point is regarding pseudomonas. Most of the cases that coming from outside, they don't have pseudomonas. Pseudomonas is usually found in ICU setup. That is iatrogenic, if I say. Klebsiella, pseudomonas, once the patient is inside ICU after third or fourth day, then only you will find pseudomonas or Klebsiella. Before that, you will not find those. These are usually ICU induced.
I think we do more on clinical parameters for antibiotics rather than see the wound. Sometimes we will not start any antibiotic for very long time. Unless we are preparing the patient for surgery or antibiotic is not very first line. Avoidance of infection is very.
The sepsis criteria for burns is quite different from normal sepsis. So we don't use. Till 1.5 years, the burn patient might have fever without any burn wounds. That is due to hypermetabolism. So usually we only give paracetamol and that subsides.
People in burns due to hypermetabolism. Not always.